lovely lunch. So we stopped earlier on, we stopped at before lunch where I was talking about the different types of decelerations. So there are 4 types, as I mentioned. Can people hear me at the back? Can you hear me okay? Yeah. So there are 4 types of decelerations: earlies, lates, variables, and prolonged. Now, anything I'm going to say is on your handouts that you will be getting. I might ask Dia to say a few words later on about how you access the handouts, or they might go on maybe the Institute's website or something. When we talk about early decelerations, so early decelerations are caused by stimulation of the parasympathetic nervous system, which causes a decrease in the fetal heart rate. When do you see, and it was mentioned this morning, when do you most often see stimulation of the parasympathetic nervous system in the fetus during labour? At what point in labour? So at what point during labour would you normally see early decelerations in particular? During contraction, exactly. And what stage of labour in particular? Second stage. So early decelerations are most commonly seen during contraction phase, late in the first stage, and during the second stage of labour, suggesting they have something to do with head compression, isn't that right? So early decelerations are associated with fetal head compression, but we need to avoid making the mistake of assuming that all early decelerations are due to head compression. So for example, if you have a multiparous woman and you do an abdominal examination and you find the head is free, not engaged, and you've got early decelerations on your tracing, it should be a cause to keep a very close eye, because it's likely that that tracing will deteriorate further, or it may deteriorate further, because there isn't head compression which should be stimulating those decelerations. So that's different to the situation where you've got a mother where the head is well engaged, there's good descent, the head is being compressed, and you've got early decelerations. So I just want to go through with you, and I know you all know this, but bear with me for a few minutes, what an early deceleration looks like and its characteristics. So thank you. I have to say that I've never seen such very good support, IT support. This is great. Genuinely. So we flipped from a laptop to the iPad really quickly and really easily, so thank you. So with an early deceleration, so if you have a contraction here, with an early deceleration, if you just draw some imaginary lines here, that's the onset of the contraction. This is the peak of the contraction, allowing for a lot of artistic license. I'm not a very good drawer. And this is the end of the contraction. An early deceleration has a gradual onset and a gradual recovery. Because it's a gradual onset and a gradual recovery, it tends to have a U-shaped base, doesn't it? But that's not always the case. It may not have a U-shaped base, and I'll come on to that in a moment. The onset of the contraction, the onset of the deceleration is at the onset of the contraction. The lowest point of the deceleration is at the peak of the contraction. And the heart rate has returned to the normal rate by the time the contraction has subsided. But you can also have a deceleration that looks like this: gradual onset and a gradual recovery. Can't you? That doesn't have a U-shaped base, does it? It tends to have much more a sharper V-shaped base. So we need to make sure that we can differentiate why might this be an early and not a variable, for example. Okay? So one of the, as I mentioned to you earlier on, some of the tips I would give you, one of the tips is make sure the paper speed is running at the correct speed. Running at 1 centimetre a minute, check it. Number 2 is to make sure that you are genuinely monitoring a fetal heart and not a maternal tachycardia by mistake. And that's done by checking the maternal pulse. The third major tip that I think is when it comes to CTG interpretation is that if you have decelerations, ask yourself the question, do they have gradual onset and gradual recovery, yes or no? Does the tracing have gradual onset, gradual recovery, yes or no? So with the early decelerations, they are not associated with fetal hypoxia, they're not associated with acidosis, and they're not associated with a low Apgar score. So they are reassuring. So the classification would be reassuring. But do bear in mind the overall clinical picture. If you do have early decelerations, in the absence of fetal head being compressed, you should be alert to monitor more closely because the pattern may change. So I don't know, can we flip over to the laptop? Can we flip over to the laptop again? Is that possible? Do you want this lead? Do you want this lead? Give me 1 second. I'll continue with this for a second. But I'll go back to the slides again in a second rather than jumping back and forth. I'll show you some examples of early decelerations in a moment. Is that okay? If we just go through some of the patterns. So a late deceleration when does a late deceleration begin? Over here? No, exactly, yeah. Anywhere from here onward. So a late deceleration, the onset is at or after the peak of the contraction. So at any point from the peak of the contraction onward is classified as a late deceleration. It too has a gradual onset and gradual recovery. And usually with a late deceleration, the length of the deceleration is proportional, doesn't necessarily match it identically, but it's proportional to the length of the contraction. There's usually a very strong correlation between how long the contraction is and the length of the deceleration. The fetal heart rate drops by more than 15 beats, doesn't it? And it must last 15 seconds or more. Yeah. But you can have a deceleration pattern, which I will show you on the slides, where the decelerations, none of the decelerations go down by more than 15 beats. So where you have persistent decelerations of shallow depth, so they may only go down a little bit, less than 15 maybe, where you have the decelerations going down by less than 15, and where they are persistent, they are an ominous or bad sign. Okay, so the classic definition of a deceleration is a fetal heart rate 15 beats below the baseline, lasting for 15 seconds or more. But there's an exception to that, and that exception is where you have shallow decelerations of any magnitude. They should give cause for concern and much closer observation. And I'll show you some examples of that. Late decelerations are associated with hypoxia, with acidosis and a low Apgar score. So they are associated with adverse outcomes. However, and you know this from your clinical practice, most infants who display late decelerations will not be compromised, truly. But they are at a much greater risk of being compromised than infants who don't have decelerations at all or who have early decelerations. Would you agree with that? Yeah. Okay. So, our colleague this morning who gave the talk on the pathophysiology of the CTG, so I said earlier on that the normal intrauterine pressure of the pregnant uterus at rest in millimeters of mercury was about 12 to 20 millimeters of mercury. So there is pressure inside in the mother's uterus when the uterus is at rest. And the fetal heart is beating along comfortably. As the contraction and the intrauterine builds up, the intrauterine pressure rises, doesn't it? Now, in the umbilical cord, you have your two arteries in a vein. If that umbilical cord becomes compressed, what's the first blood vessel or vessels that will become occluded or blocked? The vein. Why? The walls. Good. Less muscle architecture in the walls. So with that contraction increase and the increase in intrauterine pressure, the vein will close, causing a baroreceptor response and causing a temporary increase in the fetal heart. As the contraction continues, what closes? What becomes occluded? The arteries, don't they? And that causes a temporary decrease in the baby's heart rate. As the contraction subsides, what opens? The arteries. So the pressure has come on, squeeze and close the vein, squeeze and close the arteries. As it's easing off now, the arteries are springing back open again. Baby's heart rate due to a baroreceptor response increases. And as the contraction eases off entirely, the vein will then open once the pressure drops below about 15 millimeters of mercury. This deceleration here demonstrates abrupt onset and rapid recovery, doesn't it? Usually, not always, but usually about less than 30 seconds to go from the peak to the nadir, and likewise on this side. Usually 30 seconds and 30 seconds or less. But the key characteristic of this type of a deceleration is that it has an abrupt onset and rapid recovery, unlike earlys and lates, which both had a gradual onset and a gradual recovery. Okay? So where does the contractions occur in relation to a variable deceleration? This has all the characteristics of what we call a variable deceleration, hasn't it? But where can the contraction occur? It varies, doesn't it? Variable, it varies. The contractions can occur anywhere that deceleration can occur anywhere along the contraction phase. Do you all agree with that? Does everybody agree with that? Because this is now my challenge to you. Does everybody agree with this? Yeah? Okay. So therefore, if you agree with that, then the contraction can occur here. Yeah? Everybody happy with that? So you just all agree that it can occur anywhere in the contraction phase. So therefore, it can occur with the decelerations. Do you all agree with that? Yeah? There's sometimes an assumption that for something to be a variable deceleration, sometimes people think that a variable deceleration is the presence of earlys and lates. Some earlys and some lates makes the pattern variable. Have you heard that being said? Sometimes? That's not the case. If the deceleration pattern, not just the one deceleration, if the pattern, the overall pattern, shows abrupt onset and rapid recovery, the pattern is variable decelerations, irrespective of where during the contraction phase it occurs, including if it occurs with the deceleration. Does that make sense? If the overall pattern is gradual onset and gradual recovery, then it must be earlys or lates. And now you need to look at the contractions to determine which it is. So my next tip is, if you have decelerations, ask yourself the question, I have decelerations, are they gradual onset or gradual recovery? If the answer is yes, you must conclude that they are earlys or lates. If the answer is no, they must be variable or prolonged. And prolonged are easy. Yeah? Okay? So variable decelerations also display these features. And all of this is on your slides, and we'll go through this briefly in a moment. They display this shouldering characteristic. See this shouldering characteristic here? These shouldering characteristics. This here is how you would expect a baby who's capable of responding physiologically, normally, to umbilical cord compression. This is how you would expect that infant's, that fetus's heart to respond. So shouldering is a good sign. It means the baby is capable of demonstrating a physiological response to umbilical cord compression. So the presence of these shoulders is a good sign. Yeah? The other things that can happen is you can have these, which is overshoot on recovery. So after the contraction, it's gone much higher or significantly higher. Can you see that along here? That suggests that baby is becoming compromised. It's now less able to demonstrate a physiological response to umbilical cord compression. So it's concerning. The third type of shouldering is probably the easiest one, is something like this. What's going on here? There's no shouldering at all. And the way I've drawn that is deliberate. Can you see there's very little variability there? And most often when you see an absence of shoulders on variable decelerations, it's associated with a reduced baseline variability. And as you can imagine, that suggests that baby is less well able to cope with umbilical cord compression. So you want shoulders, they're a good sign. Overshoot and recovery is the next level of compromise, and the absence of shoulders is the worst level of compromise. It does not mean that every baby that has got an absence of shoulders will be compromised, but it does mean that those infants are at greater risk, increased risk of being compromised with overshoot and recovery, and even more increased risk with the absence of shoulders entirely. Does that make sense? Variable decelerations have a varying effect on the baby. So they may or may not be associated with genuine compromise, genuine hypoxia. So the best way of determining how that baby is doing is looking at all the other parameters also. Color of the liquor, the baseline variability, the baseline rate, all the other features which are important for any assessment. They should be very high on your minds when you're assessing how good this baby is. There are other examples. So you'd all agree with me, this is the typical variable deceleration, isn't it? Abrupt onset, rapid recovery with shoulders. So overshoot on recovery is atypical, isn't it? Absence of shoulders is atypical. Yeah? Biphasic. Biphasic decelerations are atypical. Rising baseline. Atypical. Prolonged recovery, atypical. They're the most commonly found atypical decelerations, and there have been reported 40 different types of atypical decelerations. You don't need to know 40 different types of atypical variable decelerations. We just need to know what the typical is. Anything else is atypical. But these ones are the most common ones. Overshoot on recovery of the shouldering, absence of shouldering, biphasic, and rising baseline. And the last one, prolonged recovery. They're the most common ones. Is that okay? Yeah. And I might flip back to the iPad if that's okay, or to the laptop, please. Yeah, if you can't hear me, shout. So I'm going to pass by these because I've said anything that's on the slides. I've said a lot of what's on the slides here. But I want to show you this. So this is an early deceleration pattern. Given what I've shown earlier on, do you all agree with that? Just take a moment to look at it. It doesn't matter that it's got a V in the bottom. It's a gradual onset and gradual recovery. Does that make sense? That's the key. Most early decelerations will have a U-shaped base, but quite often they won't. But they will have a gradual onset and gradual recovery. So this pattern here is early decelerations. And interestingly, truly uniform, true U-shaped, I was taught early decelerations are mirror images of the contractions. That actually, I was taught if you turn it upside down, it should look the same, the contractions. They are rare, very, very rare to find a deceleration pattern that is that consistent and uniform. That doesn't happen in the real world. Very rarely does true uniform early decelerations happen. So late decelerations are probably one of the easiest ones, I think. Very few people inappropriately assess late decelerations. Would you agree with me on that? Does the onset happen at or after the peak of the contraction? Is it gradual onset, gradual recovery, therefore it's late? So these are some examples of late decelerations here. I think you'd all agree they're very clearly late decelerations. They're very clearly concerning patterns. By the way, just sometimes different units, different countries we use 1 centimeter per minute, but our graph range, we sometimes use a 30 to 240, and we sometimes use a 60 to 220 rate paper. It just might squash things up a little bit, but the interpretation is the exact same. These are more late decelerations. Again, be cautious of these here. These may not go down by your requisite 15 beats per minute, but they are concerning. Now, these are your variable decelerations. And this particular tracing, these are very exaggerated shoulders, aren't they? But that's just for teaching purposes. The abrupt onset, rapid recovery. So the shouldering is a good sign. It suggests the baby is coping physiologically with umbilical cord compression. This next slide is the slide I want to show you that I think some people, not necessarily here, but I certainly know in the countries I have been to, would often have interpreted this next tracing as earlies. And I'm making the argument it's not. They are variable. And I just want to check that you are comfortable with that. Is that okay? So please tell me if you think I'm wrong. These are sometimes called earlies. Can you all see that? Would you agree that sometimes you can understand why they are, but can you see why they are very clearly not early decelerations? The fact that they are all associated with the contraction is irrelevant. They meet the definition of a variable. They do not meet the definition of an early. Early deceleration is gradual onset, gradual recovery. None of them meet that criteria. Variable deceleration that occur anywhere in the contraction phase, including can occur with the contraction. This happens here, okay? Now, why is it important? It's more than just words. It's important because if you say early decelerations, you would take false reassurance from knowing that early decelerations are not associated with hypoxia, acidosis, or low Apgar score. But in this particular case, they're not early decelerations. You need to be more concerned and look at other features that might tell you how this baby's doing. So what else is going on here? What else do you notice about the variable decelerations? Shouldering. So there's overshoot on recovery, isn't there? Not with every one of them, but as a pattern overall, most of them are showing overshoot. People will often say to me, Declan, but this one here, this one deceleration, we don't care about one deceleration. If I showed you a pattern of early decelerations and there's one late, the overall pattern is early. And you're not going to be concerned about that one late. In the same way, if I showed you a late pattern and there's one early, you're not going to be reassured because there's one early. It's never in fetal monitoring about the isolated deceleration, it's about the pattern. So this is a pattern of variable decelerations with overshoot on recovery, suggesting a baby may be becoming compromised. The baseline variability in this particular tracing is about 5 to 10 beats per minute, certainly about 10 beats per minute, depending on the minute you might take. So in this particular situation, there was required assessment of the overall pattern What stage of labour is this mother in? Is this her first or subsequent labour? Has she had a successful vaginal birth in the past? Position of the baby, descent, rotation, etc. All those other factors will feature into your decision making. So for example, if I said to you, this is a mother, this is her second pregnancy, she's at term, a previous spontaneous vaginal birth 2 years ago, she's at term, and the vertex, cephalic presentation, and the vertex is at the spines. 0. You would think, okay, I'm pretty happy with this. If I said to you, this is a first-time mother, the descent is -2. She has begun involuntary pushing, and the head is slightly deflexed. You'll be much more concerned here. You're going to have to take a decision to do something in this regard. You can't afford to be waiting the next anticipated 1 hour plus. Yeah? So you take all the other features into account. But the key thing I'd like you to take from this is that that the differentiation between variables and earlys or lates is not to do with when they come in relation to the contraction. It's to do with the onset and the recovery. The only time that the contractions become really important is differentiating between earlys and lates. So they're the 3 types of shouldering. So this is in your handout. The normal physiological response, the overshoot and recovery, and then the absence of shouldering. So these are the types of atypical decelerations I mentioned to you. The loss of primary or secondary rise in baseline, which is the loss of the shouldering. This just means the shouldering. A slow return to the baseline at the end of the contraction. That's the one goes down but takes a while to come up. Prolonged secondary rise in baseline, where it goes down but it goes up, and it goes up to a higher baseline rate. A biphasic, which is the W base. Loss of variability during the deceleration. Even during that period of variable decelerations I showed you, the variability was still very good, even at the lowest point of the deceleration. Or continuation of a baseline at a lower rate, much rarer, is where the deceleration goes down and it comes back up, but it comes back up to a level that's lower than the initial baseline. Why is that much more unlikely to happen? The normal fetal physiological response to hypoxemia is to do what with the heart rate? Increase it, isn't it? Not decrease it. A decreasing fetal heart rate is very concerning, particularly if it's associated with a chronic abnormal fetal heart rate pattern, because that might be suggestive a baby has lost any compensatory mechanisms to deal with whatever insult it's being faced with. So just take a moment to read this here. I'll give you a moment just to read this slide. This is the NICE, or the NICE and the RCOG classification for variable decelerations. As I said, you want to be able to tell each of the features, the baseline rate, the baseline variability, and the decelerations. Classify each of those features, those 3 features, into reassuring, non-reassuring, and abnormal. So reassuring is variable decelerations are present, but there's no concerning characteristics for 90 minutes. Non-reassuring is variable decelerations with no concerning characteristics up to 90 minutes. For 90 minutes or more. Or variable decelerations with concerning characteristics now, which is the atypical periods I mentioned, in up to half of the contractions for more than half an hour. Variable decelerations with any concerning characteristics in over half of the contractions, but for less than 30 minutes. They're all non-reassuring. And abnormal is anything else. I mentioned to you earlier on that, can you see it becomes, you can say, oh Lord, how do I remember all of this? I certainly do. and I've been teaching it a long time. So I think we need to have tools that isn't looking, it's not, obstetrics and midwifery is not a memory test on the spot. It's can you interpret the tracing and take a decision on the best care for that mother and baby based on that interpretation. And we should be using the tools to help us do that. And there are some tools available. And I'll come on to those in a second. So I'll come back to the classification in a second. Prolonged decelerations are easy. A prolonged deceleration is a drop in the baby's heart rate that lasts at least 2 minutes. In my country, we often have midwives saying, I've got a prolonged deceleration on Mrs. Murphy in room 6. Could you please come and give me your opinion? In actual fact, in most cases, they'll say I have a bradycardia, beg your pardon, they'll say I have a bradycardia. In most cases, when midwives in my country say I've got a bradycardia, it's not. It's a prolonged deceleration at that point. It may become a bradycardia, but a prolonged deceleration is a deceleration that lasts at least 2 minutes. At what point does a prolonged deceleration become a bradycardia? How long does it have to be down before it's now a bradycardia? It might surprise you. It's longer than people think. So it has to be down at least 2 minutes. Between 15 seconds and 2 minutes is a deceleration. After 2 minutes is a prolonged deceleration. At what point is it now a bradycardia? Someone said there? It's 10. 10 minutes, which sounds like a long time. But a deceleration lasting 2 to 10 minutes is technically a prolonged deceleration. And after 10 minutes, it's a bradycardia. I am not saying that you treat those any differently. 8 minutes or 11 minutes, that you're going to be treating them any differently. You're still going to be concerned at that point in time. But in terms of the technicality of the language, a prolonged deceleration is 2 to 10 minutes. In most cases, when an obstetrician is called to the room, the midwives will not have waited for 10 minutes. So you will be faced with a prolonged deceleration rather than a true bradycardia. It may stay down and become a bradycardia, but in terms of the definitions, it's important just to make the distinction. Prolonged decelerations go down rapidly, usually a profound drop by at least 30 beats a minute. It can occur anywhere in relation to the contraction. Usually the contractions are continuing during the prolonged deceleration, and there's a gradual recovery to the baseline. In terms of classification, these are the classifications that are used. If it's less than 3 minutes, it's non-reassuring. If it's more than 3 minutes, it's abnormal. So here's an example of a prolonged deceleration. If that had come up 30 seconds earlier, it would be a bradycardia. Sorry, if it stayed down 30 seconds later, it would be bradycardia. So if we count the minutes, on this paper here, each of those little boxes is 30 seconds. It leaves the baseline here, 1, 2, 3, 4, 5, 6, 7, 8, 9. The 10th minute ends here. So can you see? It doesn't look as long as you think it might do. So this is a prolonged deceleration, not a bradycardia. Can anyone tell me what's the likely cause of this prolonged deceleration? It's on the screen. What happened here? Yeah, someone said tachysystole. It is hyperstimulation, but it's not tachysystole. 1, 2, 3, she's only 5 contractions in 10 minutes. That's not tachysystole. Tachysystole is more than 5 in 10 minutes, but it is hyperstimulation. What's the type of hyperstimulation that it is? Mentioned it earlier on this morning. 2 types of uterine hyperstimulation. One is tachysystole, and the other is hypertonic. So this mother gets resting tone here and doesn't achieve resting tone again until another 7.5, 8 minutes later, where resting tone is achieved here. See the rising resting tone. What's the cause of that? What happened here? Oxytocin. Oxytocin. So you're all saying syntocin or oxytocin. You've all seen this happen, I'm sure, with oxytocin. So what then is the black mark? What happened? if you note the contractions here stopped immediately. Okay. So if you stop syntocinon, it won't stop that fast, will it? It won't just have a cold, absolutely just stop. Now someone said to me, and I thought it was a very good point, someone said, rupture, which is a very good diagnosis because that could be a severe rupture, but it wasn't, thankfully. So this here in this particular case was this, they gave terbutaline intravenously to counteract the effects of the oxytocin and cease uterine activity. So it's a measure that's recommended in many guidelines that if you have a severely abnormal fetal heart rate pattern secondary to uterine hyperstimulation caused by oxytocin, administer terbutaline intravenously. And it stops the contractions immediately, as you can see. And interestingly, on this particular baby, if you note what happens once the contraction stops, the fetal heart rate gets a chance to recover to its baseline. So you're further reinforcing that this baby was certainly being compromised as a result of the hypertonic uterus that was going on here. So a couple of simple things that I'll go through a little bit more quickly. So tachycardia is an increase in the baseline above 160, isn't it? But also watch for baselines that are 20 beats above the admitting baseline. So if you have a mother that comes in and her baseline is 120, the fetal baseline is 120, and it rises to 140 or 145, we should be concerned. A rising fetal heart rate baseline is one of the first signs of fetal hypoxemia. Not hypoxia, but hypoxemia, a falling blood oxygen circulating level. What's the cause of the prematurity? Try and investigate it. Is it maternal pyrexia? Is it maternal infection, chorioamnionitis, for example? Is it prematurity? Common cause of tachycardia. And if you've got a premature infant and you've got a tachycardia, you now have a physiological explanation for the tachycardia. So if I showed you a tracing of a 32-week fetus with a baseline of 175, I imagine most of you in the audience would be fairly, particularly those of you who are experienced, would be fairly comfortable with that, would you? 175 on a 31, 32-weeker, you'd probably be fairly comfortable with that. And I would agree with you. If I showed you 175 on a fetus who's 42 weeks gestation, you're not too happy, are you? Yeah. Here's an interesting one. What's the normal baseline fetal heart rate? 110 to 160 beats a minute. How many of you have seen a CTG on a 32-week fetus? Seen a CTG on a 32-week fetus? Hands up if you have. 34-week fetus. Seen a CTG on a 34-week fetus? Yeah, lots of you have. How many of you will be happy with a baseline fetal heart rate of 110 on that baby? No, nobody's happy. What did you just say the normal fetal heart rate was? But you'd be happy with the baseline of 170? What did you say the normal was? So you were unhappy with a normal baseline rate, and you were happy with an abnormal one. And that answers, and I agree with you, and that's the challenge you asked earlier on. We don't have good criteria to apply to the preterm infant because of the physiological shifts. You all know that there is a world of difference between a 24-weeker and a 26-weeker. Between a 30-week fetus and a 32-week fetus. Every week makes a significant difference to a fetus, particularly prior to 36, 37 weeks, doesn't it? So we probably will never have gestational specific interpretation criteria because they're so dynamic as the fetus moves. The other really interesting thing, which I always make the argument that we probably shouldn't even try to do it, because the other physiological piece of information we do know to be true is that the chemoreceptor response, not the baroreceptor, the chemoreceptor response in preterm infants is unpredictable. Some infants will respond differently to other infants to changing circulations of blood oxygen, carbon dioxide, lactate, than the same infant at the same gestation exposed to the same insult. It's unpredictable. So having criteria to interpret is going to be very difficult for the severely preterm infants. And by the way, Indonesia is no different to the rest of the world. All we can do throughout the world, if we use CTGs on preterm infants, is our best. There is no golden textbook saying this is how you should interpret CTGs and take decisions on severely preterm infants. One of the most difficult decisions in maternity care, I think, and in some countries this happens, where CTGs are performed on babies as young, fetuses, as early as 28 weeks gestation, for example, or even earlier. And one of the hardest decisions that I think is to be made is, what happens if you have a grossly abnormal 28-week CTG? What do you do? Because no matter how good we think we are in maternity care, you know that we really, in that situation, have just one of two decisions to make. Nothing, or deliver. And I think it's a very brave person who will take a decision to deliver and expose that baby to the rigors of potential mortality and morbidity, particularly in countries where the resources to support that infant successfully might be limited. So I would always urge people to question, before you put a CTG on a very preterm infant, ask yourself the question before you put it on: what am I going to do if this is not okay? You always do it to check if the baby's okay. But what happens if it's not? Don't ask yourself that question when you have the tracing that's not okay. Ask yourself that question before you decide to do it, because it's a very difficult position to be in. And I've been asked on labour wards or telephoned, Declan, I'm sending you a tracing. This infant is 29 weeks. What do you think? I'd say, this is not good. So by any definitions internationally, this is a severely pathological tracing for term infants. For the preterm infants, I don't know how that baby is going to respond, because that baby's chemoreceptor response is unpredictable, etc. It's very difficult one. So please be aware of that. There isn't black and white answers. So this is a tachycardia. What's the cause of this tachycardia? It's on the screen again. Now this is your tachysystole. Yeah? Tachysystole, excessive frequency of contractions. And the TOCO is not set properly. It's not set to what we know to be normal intrauterine pressure, resting tone. It's not set properly. By the way, on this tracing also, this is oxytocin again. When the contractions are starting to become more reasonable, the baby's heart rate is starting to recover to normal. A bradycardia is a baseline less than 110. Yeah? And a bradycardia in the presence of reduced baseline variability and decelerations is a bad sign, isn't it? But if you flip that on its head, you can have a bradycardia. The reason I have this here is there have been cases where a baby has come in and it displays this type of a pattern. And the midwives or obstetricians indeed have said, oh, it's a sleep type pattern, the baby's asleep. You only know the baby's been asleep if you have a normal tracing beforehand and a normal tracing afterwards. So you can't afford to wait much longer than the 40 minutes to make sure it's a sleep type pattern and not a hypoxic type pattern. So that's the sleep type pattern here. Can you see that? Yeah. Baby's just gone to sleep. So we would suggest that in those types of tracings that we shouldn't be leaving that go for any more than longer than 40 minutes. And we should be intervening very simply. Abdominal examination, change of maternal position, out of bed, reattached to the monitor, perhaps a vaginal examination to see can you provoke a response through digital scalp stimulation. Sinusoidal pattern, to use the term sinusoidal pattern. So a sinusoidal pattern is regular oscillations of the fetal heart. It's not jagged, it's not sharp, it's regular oscillations of the fetal heart. Most tracings that a midwife or obstetrician writes down, query sinusoidal, will not be sinusoidal. And those of you who are very experienced will know the difference between them. And those of you who are very experienced are probably very open to your junior staff writing down query sinusoidal. Much better write down query sinusoidal and get it confirmed than ignore it entirely. Yeah? So in my experience, people say, Declan, I think I might have a sinusoidal tracing here. Could you have a look? And we may conclude it's not. That's much better. And I think I have sinusoidal tracing. I'm not sure. I'm not going to do anything about it. So it's characterized by regular oscillations in the fetal heart. I'll show you here in a second. So here's an example. In this particular case, the midwife wrote down in a hospital I worked in, query sinusoidal tracing. Now, those of you who are around labour wards a while will probably disagree that this is sinusoidal. It's not sinusoidal. It's too sharp, and I would agree it's not sinusoidal. But I understand any clinician writing down query sinusoidal and getting a second opinion on it. If this was a true sinusoidal tracing, you'd have, first of all, it doesn't have sharp edges. It has more looped edges. And it has between 2 to 5 of these oscillations every 5 minutes. 2 to 5 of these in a 1 minute period. 2 to 5. 2 to 5 of these loops in a 1 minute period. Does that make sense? So do you see these here? If you take this minute here, for example, there's 1, 2, 3 of these in 1 minute, yes? In a true sinusoidal tracing, you have between 2 and 5 of those loops in a 1 minute period. 1 minute is 1 centimeter. And you have between 2 and 5 of these loops in a 1 minute period. How high up, the difference between how high up it goes and how low down it goes, which is called the amplitude, the depth of it, is between about 5 to 15 beats per minute at least. Could be higher, but at least 5 to 15. So if we get another example. Now this tracing, some of you may say, I still don't agree that this is a true sinusoidal tracing. We are now on this line point here, we're into 90 minutes of a very similar type tracing, despite change of maternal position, strong regular contractions, and 2 vaginal examinations, none of which has provoked any response, fetal response. No accelerations, no decelerations, nothing. So despite external stimuli, this has remained consistent. Now this to me is much more alongside true sinusoidal patterns. Some people in the audience may say, I still don't buy this true sinusoidal. And it doesn't really matter. The key is that if you think it may be, to seek second opinions and not to ignore it. If you subsequently decide it's not a true sinusoidal, that's okay. But you've done something to confirm that it's not. The textbook sinusoidal tracing means you can cut out a minute, cut it out, and drop it on any other minute, and it'll match up. It's identical. But true sinusoidal tracings, that textbook, rarely happen. True sinusoidal tracings are a concern because they're associated with 2 severe things, severe fetal anemia and severe fetal hypoxia. And they usually don't change in response to external stimulus because you can't reverse hypoxia. You can't reverse anemia. You can, but in the rigors of labor, you're not going to. So these are the guidelines that this talk has largely been based on, which is the Intrapartum Care Guidelines from NICE, updated in 2017. That's on your reference list in the handouts. They're just the Irish guidelines. And I have the Irish guidelines there just as a means to show that an awful lot of countries are very similar today in how they interpret systematically the CTG tracings. You may say to me, well, in Indonesia we do something slightly different, but the differences today are likely to be very subtle. Between the ACOG, America, Canadian, Australian, New Zealand, and RCOG, the criteria for interpretation are very, very similar today. Yeah. So what we've done should be useful. So I said earlier on, this is putting it all together. This is on your handout. This is in the NICE guidelines, which is freely available to download from anywhere. So this table is in the handout, and it summarizes all of the three features: baseline rate, baseline variability, and decelerations. And it tells you for each of those three what reassuring, non-reassuring, and abnormal is for each of those three features. Does that make sense? So it's worth having a look at it. And it goes on then to say, so this is an example then. I'm sorry you can't see this, and you probably won't be able to see it very well in your handout, but let me explain briefly. What we've done is, in one of our hospitals, is we've taken the criteria, and we've said, let's make it easy for clinicians. So this is a sticker. It's about this size. About that size. And it goes on the mother's records. And what it does is, you look at the tracing, and it's got baseline rate here, baseline variability running along here, accelerations running along here, decelerations running along here, contractions are running along here, and it asks you, it lists out the criteria from NICE, what reassuring is, what non-reassuring is, and what abnormal is. And you come along as a midwife or an obstetrician and you just circle. You come along and you say, okay, the baseline is 141. I'm going to circle here. You're going to say there are no accelerations in the last 20 minutes. I'm going to circle here. You come to the variable deceleration and you say there are atypical variable decelerations for more than 50% of contractions for more than 30 minutes. That means I'm going to circle over here. Does that make sense? So it very quickly allows you to document your systematic interpretation and determine within each of those criteria whether it's reassuring, non-reassuring, or abnormal. And it stops this memory test. I think part of the problem with our use as clinicians of these guidelines to their full extent for fetal monitoring has been, you have to remember all these things. Variable decelerations, okay, is it typical or atypical? If it's atypical, it has to be for more than 50% of the contractions for at least 30 minutes to make it non-reassuring. It just starts to get really difficult. So I encourage you to try to prepare some of those. I'm happy to share a PDF of that with Rena, who can pass it on. And we've passed that on to our 19 maternity units in the area we work with. They all use this now. They send it to the printer, it got printed up. Actually, some of the units made a stamp. Just stamp it in the page. But it makes it really easy for you to do your interpretation. We have sat down with clinicians and asked them to interpret tracings and see how long it takes them to systematically, comprehensively document interpretation. And this takes an experienced clinician less than 15 seconds to document their systematic interpretation of the tracing. That's impressive. And the nice thing about them is it means that everybody is using the same criteria. We also have one for antenatal. The antenatal one doesn't have the presence of decelerations on it. Okay? So I'll send that on also. You may or may not decide to use it. We base this on another organization called PROMPT. Have you come across PROMPT program? The PROMPT is a program for obstetric emergencies based out of the UK, and it's being associated with the reduction in perinatal mortality. It provides training in obstetric emergencies, in particular postpartum, multidisciplinary. They will not conduct the training unless it's multidisciplinary, with midwives, anesthetics, and obstetrics. and they look at PPH, eclampsia, eclamptic fit, uterine rupture, umbilical cord prolapse, and CTG. And they have some criteria for antenatal CTG interpretation. So once you classify the features, you come along then and you're very easy, if you decide how do you classify the whole tracing? So remember, NICE or RCOG and lots of other organizations ask you to look at the baseline rate, the baseline variability, and the decelerations, and classify each of those as reassuring, non-reassuring, and abnormal. Now, when you come to classify the overall tracing, you put all that together. And they say, very easy, if all of those features are normal, or if all of those features are reassuring, the tracing is classified as normal. If one of those features is non-reassuring, and it suggests actions that you consider depending on your classification of the tracing. Personally, and this is just a personal opinion, I never worry about what midwives or obstetricians classify the overall tracing as. I'm not really bothered if somebody writes it down as normal, suspicious, or pathological. What I am always concerned about is, have they interpreted the baseline rate, the baseline variability, the accelerations, the decelerations, and the contractions accurately? If so, have they a plan of care? And is that plan of care, does it match that interpretation and the overall clinical picture? If it does, I don't care what they classify it as. It doesn't really matter, does it? But your systematic interpretation and your plan of care is what hugely matters. So just as a brief recap, what we've looked at is the baseline rate. Normal range is 110 to 160. Over 180 is abnormal, and less than 100 is abnormal, and anything else is non-reassuring. The baseline variability is the push and pull between the sympathetic and the parasympathetic nervous system. And it's that jaggedness or interplay that you find between those systems, and it displays itself on the tracing as variability. How do you quantify it? You look at the overall pattern of variability, and you choose a minute that you think this is very reflective of the overall pattern of variability. Take the 1 minute, the 1 centimeter, see how high up the fetal heart rate goes and how low down it goes, and subtract one from the other, and that will give you your baseline variability in beats per minute. For example, it went as high as 130, down as low as 110. 130 minus 110 is 20 beats a minute. If you're not sure if you took the right minute, ignore accelerations and decelerations, remember, and choose another minute. It should give you near enough the same answer. Does that make sense? So with baseline variability, what you're looking for is, what is the overall pattern of variability, excluding accelerations and decelerations, and I want to find that minute, see how high it goes in that minute, see how low down it goes in that 1 minute, subtract both. That's my baseline variability. Accelerations are easy. 15 beats above the baseline, lasting for 15 seconds or more. If you have 2 or more accelerations in 20 minutes, it's called reactive. Reactive doesn't mean anything else. It only says, so if I'm Declan Devane, 0920 CTG reactive. That means when somebody else looks at the tracing, from 9 o'clock to 20 past 9, there were 2 accelerations. Doesn't mean anything else. Decelerations, 4 types: earlies, lates, variables, and prolonged. And remember my tip. Ask yourself the first question if you have decelerations is, and try this, ask yourself, are they gradual onset and gradual recovery? If so, they have to be what? Earlies or lates. Isn't that right? Gradual onset, gradual recovery. Earlies or lates. How do you find out which? Look at the contractions. If they're with the contractions, they're earlies. If the deceleration is happening at or after the peak, They're lates. A variable deceleration, abrupt onset, rapid recovery. Tend to have a V-shaped base. Not always, but tend to. Yeah? Where do they occur in relation to the contractions? Anywhere. Before, all during, all after, or a mixture. But the key differentiation is the abrupt onset and rapid recovery. Check for shoulders. Shouldering is a good sign. Overshoot and recovery, not a great sign. And the third sign you want to avoid is where you've got a pattern of no shoulders at all. Absence of shouldering. Variable decelerations have a varying effect on the baby, which is why you want to look at all of the other features of the tracing and the overall clinical picture to tell you how that baby's doing. Prolonged decelerations are probably the easiest of all of them, I think. Deceleration that lasts more than 2 minutes, up to 10 minutes, is a prolonged deceleration. After 10 minutes, it's a bradycardia. Most of you clinically, when you're asked to review a tracing, if you look at the time it started, by the time you review it, it's probably going to be within the 10 minutes, if you're on site and in the hospital or the unit. Would you agree? Yeah. If it's after 10 minutes, it's a bradycardia. In terms of classification, I'm encouraging you to consider in your units, we found it really helpful, is to try to shift the thinking from it being a memory test to remember all the different criteria for reassuring, non-reassuring, and abnormal for baseline rate, baseline variability, and decelerations, and instead provide some tools to make it easy for people to remember those. And your job as a clinician is to interpret that then. And the tool helps you document it. In terms of classifying it, NICE recommend, if you're a class on the RCOG, if all of those features, those 3 features are reassuring, the tracing is normal. If 1 is non-reassuring, the tracing is suspicious. If 2 are non-reassuring or 1 is abnormal, the tracing is pathological. And there are some actions listed on the right-hand side of that table, which is in your handout, and you will be able to read that easily, which show what you should be doing in terms of suspicious and pathological tracings. Very briefly, just as a maybe helpful hint, in a reassuring tracing, the usual plan of care will be to continue and observe. In a suspicious tracing, the usual plan of care will be conservative. Change of position, increase of fluids perhaps, if mother's dehydrated. A closer monitoring, vaginal assessment. It'll require an action on your part, which requires closer monitoring or more information to help you make a decision. Fetal blood sample, maybe. A pathological tracing requires a decision. Am I happy to continue with this labor? You're required to take a decision on a pathological tracing. Do I need to deliver? Or are there other actions I can take that are not just conservative now? Are there other actions that I can take? So it might be, for example, it certainly will be an assessment of progress in labor, both abdominally and vaginally. And that information will be used to inform whether you can perform an instrumental vaginal birth or whether you feel you have the time to wait until you can perform an instrumental vaginal birth or a spontaneous delivery, or do you need to bail out and do cesarean section, for example. So in terms of decision making, non-reassuring should require a conservative, but something should be done. Pathological requires concrete decision as to whether delivery is warranted or not. The last thing I want to talk about is, just very briefly, is contractions, because we often, I think it's very sad that most clinical practice guidelines in the world currently talk about CTGs and classification of CTGs without once mentioning contractions. In the NICE guidelines, you can have a CTG classified as normal with a hypertonic uterus, with tachysystole, because contractions do not feature anywhere in the criteria for assessment of the tracing. If you look here, there isn't one mention of the word contractions in terms of classifying the tracing. Now, that to me is not good. I think that contractions are a very important component of CTG interpretation. Now, people will say, well, Declan, you can't interpret decelerations without recourse to contractions. But there's more than just the timing of contractions. We're also concerned about the frequency of contractions, resting tone. So when it comes to contraction assessment, you want to find 4 things, don't you? The frequency, how often they come. The duration, how long they last. The intensity, how strong they are. And is there resting tone in between? The CTG machine will tell you how often they come, won't it? If it's set properly, and how long they last. That's all. Your hand will tell you how often they come, how long they last, the intensity, how strong they are, and the resting tone. Would you agree? Many midwives I've met and many obstetricians with some women who maybe are larger in size and can't feel contractions sometimes themselves, perhaps, or the toco isn't picking up contractions very well. I know lots of clinicians who can sense the contractions before the machine will pick it up. So your hand, and experienced hands, are much better at contraction assessment than a machine. So do try to remember that, and try to have faith and value in the low-tech clinical skills that are hugely valuable. I don't know if this still happens in Indonesia, but many years ago I was working with an Irish obstetrician who was 44 years working in labour ward in a large hospital, about 12,000 births. But he was doing a ward round with the juniors, and he was explaining in the ward round the abdominal examination features that you would feel of a brow presentation. Yeah, brow presentation? Brow presentation. In English textbooks, they don't talk anymore about what you would find abdominally on a brow presentation at all. It's not mentioned. They'll tell you what you'll feel vaginally, but they don't mention abdominal examination. It's actually gone from the textbooks, being lost. In the same way in many developed countries, can I ask you, in Indonesia, breech births, so primogravidas with breech birth, how are they born, babies? Vaginal? Vaginal? Could be vaginal, could be. So in most of Europe, so in the UK, for example, in Ireland, it would be very unusual today to find a primogravid mother with a breech presentation having a vaginal birth. Very, very unusual. Very unusual. And there are some units where if a mother comes in with a primate breech presentation, fully dilated, she will have a cesarean section. That happens. Why is that happening, do you think? Sorry? Competencies, exactly. Is that right? Competencies? Yeah, exactly. It's exactly right. So you've heard of the term breech trial, have you? There was a large trial published in 2007, I think it was, by Hannah, the term breech trial it was called. And it was a large multi-center trial that randomized women with the primate breech presentation to have an elective cesarean section or to have a vaginal breech birth. And it wanted to see which was better for the mother and the baby. They did the study and they found a much higher incidence of mortality, perinatal mortality, associated with vaginal breech birth. In many developed countries, many high-income countries, literally within a year, people were doing cesarean sections for primate breech birth because of that study. A number of years later, people found that in that study, in some of the centres where women were randomized to have a vaginal breech birth, the clinicians weren't experienced at doing vaginal breech birth. Which means that in some cases, the women were being cared for by clinicians with less competency at vaginal breech birth than cesarean section, for example. Now, while concerns have been raised about the study, one of the challenges we are left with in many countries now is that this has been going on for so long, clinicians have lost the skill and the competency of successfully supporting women with vaginal breech birth. That's one of the challenges. It's very difficult now to find experienced clinicians who are there to teach junior staff how to facilitate vaginal breech birth. So in many developed countries, many high-income countries, the only breech births you're seeing today are the women who are coming in, the head is on the perineum, or the bum is on the perineum, or twins, the second twin perhaps. That's pretty much it. So I know student midwives who will go through 3-4 years of training and having seen 1 or 2 breech births. Yeah. So that's how rare it's becoming. So that sometimes is how we can lose some of the skills in some of those practical skills of using your hands are hugely valuable and hugely important. So I think that's it from me. I'll open the floor to questions now. I will send Rena copies of those stickers or handouts that you might consider using, those of you in senior positions in particular in your units. They will save you an awful lot of time. People get stamps made up of them. They're very quick and very easy. And they mean that a standardized means of assessment will become routine in your units. So thank you.